Hey folks, I'm gonna go ahead and get started here. Looks like we've got a good group in for the CE. So hello everyone and welcome. This is our eighth continuing education program in our InpharmD Masterclass series. In this series, we kind of aim to eliminate redundancy in drug information, and our goal is really to drive evidence-based care. Uh, as you're likely aware, InpharmD has a drug information database, and this database contains, at this point, over 10,000 drug information questions. After sorting through a lot of those questions um, that we receive, we've identified that about 40% of the questions that were asked have been previously asked by another provider. And so in our continuing education program, we're hoping to review some of the most commonly asked questions of the month to kind of address any questions folks might have about a topic before having the need to send that request our way. So if you happen to have a topic suggestion or just a general clinical question that you would like for us to consider for a future CE, please reach out to Janvi. Janvi, her email is janhavi@infarmed.com. Today's CE was developed by both Janvi Punyarthi, the brand manager at InpharmD, who put the slides together for today's wonderful presentation, and myself, and I'm a clinical associate professor at Campbell University, and I've also been an academic partner with InpharmD for several years now. So I'm looking forward to jumping into this. But before I do, I did want to make sure to announce that neither myself nor Dr. Punyarthi have any kind of relevant financial relationships as it relates to the content for today's material. So let's get into today's topic. Today we'll be talking about the safety and efficacy of Rezafungin for fungal infections. So today's learning objectives are before you all, and they are to identify clinical characteristics of Rezafungin. So we'll talk about some of the dosing indications, some of the adverse effects. We'll describe how Rezafungin works in the treatment of candidemia and candidiasis. We'll also look at Rezafungin and how it kind of compares with other antifungal agents. And then we'll look at the literature and take a deep dive into the major phase 3 study as well as some phase 2 studies that were conducted with Rezafungin and decipher some of the strengths and weaknesses of those studies. And then finally, we want to describe how that medical literature that's related to Rezafungin applies to clinical practice. Rezafungin, as you probably are aware, is an antifungal agent in the echinocandin drug class. It is a concentration-dependent inhibitor of 1,3-beta-D glucan synthase. And as a result of this action, it reduces the formation of 1,3-beta-D glucan. Now, 1,3-beta glucans are these linear polymers, and they're kind of comprised of linked glucose molecules. The beta 1 and 3 cleavage causes them to form these, the beta 1,3 linkage kind of causes them to form these long, straight chains. And that's important because that allows this to be a significant factor in integrity of the cell wall for funguses. And supports the rigidity and the overall strength of that cell wall. So by inhibiting 1,3-beta-D glucan synthase, by inhibiting that enzyme, Rezafungin kind of decreases our 1,3-beta-glucan, which leads to osmotic instability and ultimately cellular lysis, resulting in more of a fungistatic activity. The United States Food and Drug Administration has approved Rezafungin for the treatment of candidemia and invasive candidiasis as well in patients who are 18 years of age and older. It is an IV product. It's a parenteral drug. We give a 1-hour IV infusion of this medication. As we'll talk a little bit later, this medication has a very long half-life when given IV, especially in comparison to other echinocandins that are available. So much that it is actually only given once every week, which is kind of what is setting it apart from some of the other agents. The approved dose of Rezafungin is 400 milligrams once on day 1. So we give a loading dose. And after that, you move up to a 200 milligrams once weekly dose, sort of a maintenance dose beginning on day 8. And you can give up to 4 doses of this. Currently, there's no data beyond the 4 total doses, but the total duration of treatment with Rezafungin is 14 days after the first negative blood culture, and we continue until signs and symptoms of candidemia and neutropenia have resolved. In terms of dosing adjustments for special populations, I think it's also important to kind of note that there's no dosing adjustments for patients with hepatic or kidney function issues. This is a once weekly medication, and so I think it's important here to talk about what we do if we do miss a dose. So it's important concern to think about. Now, luckily, there is a 3-day window in which patients can receive the next dose if they do indeed miss that weekly dose. So we have that, although it's clearly not preferred to miss that. Now, outside of this 3-day window, those who end up missing the dose by greater than 3 days, but less than 2 weeks, for those individuals, they should receive the dose as soon as possible. But then we also have to revise their dosing schedule and make sure that they are receiving the future dose at least 4 days before the next dose. So there's at least 4 days in between. Those who end up missing that dose by more than 2 weeks, this is a medication that really we're only using it for about 4 weeks, and so if we miss it by more than 2 weeks, we're having to reinitiate that loading dose, that 400 milligram loading dose, followed by 200 milligrams once weekly thereafter. So certainly want to try to avoid that. Now, in terms of preparation for administration, really the important things I want to highlight are how we'll reconstitute it, and then the agents we'll use to dilute. So Rezafungin is first reconstituted using sterile water for injection, and then we can dilute that in about 250 milliliters of D5W, normal saline, or half normal saline, and that goes for the loading dose as well as the maintenance dose. So in terms of storage, intact vials should be stored at room temperature, while those that have been reconstituted can be stored between 5 degrees Celsius and 35 or 25 degrees Celsius for up to 24 hours. Now, once we dilute it, the solution can be stored at those same temperature ranges for up to 48 hours. So once it's at that dilution concentration, we can store it for a little bit longer. In terms of FDA contraindications and warnings and precautions, there isn't anything that's a major concern, but as you might expect, the agent is contraindicated in those who have hypersensitivity to Rezafungin, echinocandins in general, and really any kind of component of the formulation. So really no surprise no surprise there. There are some warnings and precautions advised by the manufacturer, specifically regarding around hypersensitivity reactions that are usually appear as delayed reactions, and they've been reported following exposure to any kind of products that contain polysorbate 80, which is used as like an emulsifying agent. So it's something to be aware of, especially if these are considered to be delayed reactions. The most common adverse reactions to Rezafungin are hypokalemia, which occurs in approximately 15% of patients who take Rezafungin. I mean, imagine that this is also tied to the fact that it causes a significant amount of diarrhea and as well as vomiting with this agent. These occur at rates of 11 and 9% respectively. Pyrexia can also occurs in about 12% of patients. In terms of monitoring parameters, the manufacturer recommends monitoring our LFTs periodically, monitoring for infusion reactions, flushing, urticaria, nausea, as well as chest tightness. So let's jump in to look at invasive candidiasis a little bit, and we'll look at agents that we commonly use for this condition, and kind of look at Rezafungin a little bit before we jump into some of the study data regarding Rezafungin. So bloodstream infection caused by Candida species or candidemia is serious. Candida is a type of yeast that normally resides, in the human body, particularly in the GI tract and genitourinary tract, without causing any kind of harm. However, when the immune system is compromised or there are certain risk factors present, Candida can enter the bloodstream, and this will ultimately lead to invasive candidiasis. Candidemia can have a lot of severe complications, such as endophthalmitis, infection of the eye, endocarditis, and really various other infections. Risk factors, though, for those infections, recent surgery, especially abdominal surgery, is associated with increased risk of invasive candidiasis. Patients who have prolonged hospital stays, especially in high-risk areas like the intensive care unit, those individuals are more susceptible due to their exposure to invasive procedures and devices like ventilators and central venous catheters. Use of broad-spectrum antibiotics disrupts the balance of normal antimicrobial flora, allowing Candida to overgrow and potentially cause infection. The use of parenteral nutrition provides kind of the direct route for Candida to enter the bloodstream as well. Those who are immunocompromised, those with HIV or AIDS or undergoing chemotherapy, those individuals are also at high risk due to their weakened immune system, particularly when this is accompanied by neutropenia. Additionally, the use of corticosteroids can also cause an immunosuppression effect that's going to further put patients at risk for invasive candidiasis. In terms of guidelines, we'll review 3 separate sections briefly, but I do think it's important to point out the similarities and then also the initial therapy that we're often using, which are our candidates. And this is going to directly relate to the literature that we'll discuss later on. So for individuals who have candidemia, who are non-neutropenic, our initial therapy are candidates. That's what we typically go for. So caspofungin, which is important in our literature review later, typically given at 70 milligrams IV as a single dose. And then that's followed by 50 milligrams IV once daily. And if you look at all of our echinocandins, we're typically giving all those on a once daily regimen. And that's going to differ in comparison to Rezafungin. We can also give individuals fluconazole 800 milligrams. This can be adjusted by weight of 12 milligrams per kilogram. Interestingly, this is our oral agent that we can use, but it also exists as an IV single loading dose, and then 400 milligrams orally or IV for selected groups. Now, for specific cases, we may choose to try amphotericin B when echinocandins or fluconazole are not suitable. Usually this dose range is between like 3 and 5 milligrams per kilogram daily. These are commonly reserved for patients who have resistant candida that are resistant to azoles or echinocandins, people who have drug intolerance, or if they're just general limitations in the availability of the other agents, would be really the only, the typical reason we might go for amphotericin. So if we look at our IDSA guidelines on non-neutropenic patients and in the intensive care unit, the exact same drugs are used for these individuals as well. Our first line therapies are still our echinocandins. And then if we go further and we look at our patients who do have neutropenia, again, we are still leaning towards the use of our echinocandin agents as our initial and preferred therapy. This becomes really important when we look at the literature and we look at the comparisons of agents that were used in these studies. The first study that we're going to be talking about is the RESTORE trial. This is our phase 3 study for Rezafungin. It's Rezafungin versus capsifungin for the treatment of candidemia and invasive candidiasis. It's a multi-center, double-blind, double-dummy, randomized phase 3 trial. They included about 200 patients, 199 to be exact, and the authors sought to compare the efficacy and safety of intravenous Rezafungin versus intravenous caspofungin in patients with candidemia and invasive candidiasis. Again, remember, caspofungin is really one of our major agents that we're going to be taking a stab at this with first. And so this is a worthwhile comparator agent to consider for this study. Study groups were evenly distributed with 100 in the Rezafungin group and 99 in the caspofungin group. We won't go through all the inclusion and exclusion criteria, but we'll highlight some important criteria. These were patients who were 18 years of age or older. They had to have systemic signs of infection that were attributable to candidemia or invasive candidiasis. They had to have mycological evidence of candidemia or invasive candidiasis from blood or a normally sterile site 96 hours before randomization. And they also had to have blood cultures that were drawn 12 hours before those individuals were randomized. In terms of exclusion criteria, it's one of the important things to identify here is that they were very selective with the types of infections that they ruled in and ruled out. So patients with prosthetic joint arthritis or septic or osteomyelitis or endocarditis, those were individuals were all excluded from the study. Patients who might have a urinary tract infection or urinary tract candidiasis all were excluded. They did exclude some individuals with liver injury as well. Patients in the RESTORE trial were randomized 1-to-1 and received IV Rezafungin with the FDA-approved dosing of 400 milligrams in week 1, followed by the 200 milligrams weekly maintenance dose. And they did this for between 2 and 4 doses. In our control group, individuals received caspofungin intravenously And again, this is like the common dose, 70 milligrams loading and 50 milligrams maintenance. They did this for no more than 4 weeks in the study. They used a modified intent to treat analysis of patients that excluded in those individuals with no documentation of a candida infection. Again, the duration was 4 weeks in total. And they looked at global cure, which consisted of clinical cure, radiological cure, and mycological eradication at day 14. They also looked at mortality in these individuals at day 30, and this was all-cause mortality. So looking at some of the results, specifically looking at the global cure rates, if we compare the Rezafungin group in that second column with the Caspofungin group in the third column, percentages of cure were fairly similar. And if we look at our 95% confidence interval, we're looking at the absolute difference here in the rates that these occurred. So this crosses 0, so we're going to say that there's no significance between the Rezafungin group and the Caspofungin group. That's similar across failure and those who are indeterminate. In terms of all-cause mortality at day 30, again, we saw a similar rate between Rezafungin and Caspofungin. There was slightly more death in the Rezafungin group versus the Caspofungin group. But again, if we look at the treatment difference, 95% confidence interval, we actually don't see a statistically meaningful difference between those as the confidence interval crosses 0. So that was at least promising for that study. In terms of safety, 91% of those individuals in the Rezafungin group versus about 85% in the Caspofungin group had at least one treatment-emergent adverse event. So there were technically more adverse events that had occurred in that Rezafungin group. The most common treatment-emergent adverse event that occurred in at least 5% of patients were pyrexia, hypokalemia, pneumonia, septic shock, and anemia. So a lot of that we had covered earlier. This occurred in about 56% of those in the Rezafungin group and 53% in the Caspofungin group. So in terms of safety, generally speaking, our Caspofungin agent appears to be a little bit safer there. The STRIVE trial was a phase 2 study that evaluated Rezafungin and Caspofungin again. In this trial, less patients were recruited. There was 183. But one thing that was different here is they wanted to look at the variable doses of Rezafungin. So they actually looked at Rezafungin without the 200 milligram maintenance dose and only the 400 milligram dose. The authors sought to compare the safety and efficacy of Rezafungin once weekly to Caspofungin once daily for the treatment of candidemia and/or invasive candidiasis. So again, Rezafungin 400, Rezafungin 400 and 200, which is the FDA-approved dose, and Caspofungin 70 milligram loading dose and 50 milligrams thereafter. Inclusion criteria were those who were 18 years of age or older. They had to have systemic signs of infection, mycological evidence of candidemia or invasive candidiasis from a sample within 96 hours of randomization. And again, here they excluded individuals who had more specific or difficult to treat infections. So it's sort of the same exclusion criteria here in this STRIVE trial that again limits the overall applicability. Patients were randomized 1:1:1 in these 3 groups to either receive the 400 milligram Rezafungin once weekly or the 400 milligram loading dose with 200 milligrams once weekly, or our standard of care Caspofungin and dosing for less than or equal to 4 weeks. There was a 30-day follow-up in this study, and the authors sought to look at the overall cure rate at day 14. They also assessed 30-day mortality, as well as an investigator-assessed clinical response. One thing, let me go back here for just a moment. One thing that's important to note in the methodology here is that the researchers actually did not power this study to detect a difference between these two groups. And so when we're looking at our results here, it's important to note that the group sizes were not powered to truly detect a difference between the groups. So you're not going to see any statistical analyses, confidence intervals, p-values, was not included by the authors. So looking at overall cure, which is the primary outcome of this study, they saw in the Rezafungin 400 and 200 maintenance dose that there appeared to be an overall benefit compared to the other agents in this group. And the same goes for investigator-assessed clinical cure rate and the 30-day all-cause mortality. Now, if we look at the baseline characteristics, the groups were fairly similar across the board, surprisingly enough. And in fact, the Apache 2 scores, even though they were fairly similar, they were about 14. The Rezafungin 400 and 200 group was actually slightly more severe. And again, this is kind of a measure of mortality, expected mortality for these individuals. So that's important to note, but it's also extremely important to keep in mind the group sizes here. They're not really well balanced in terms of number of individuals in the group. There's also, again, the researchers did not power the study to really detect a difference. Even though these numbers look favorable, I think it's important to note that the study wasn't conducted for a statistical comparison. In terms of safety, treatment emergent adverse events occurred in 87% of the Rezafungin 400 group and 92% of the loading dose and maintenance group. In the Caspofungin group, significantly, or rather, far fewer patients experienced treatment emergent adverse effects at 80.9%. So that's certainly in favor of Caspofungin. But then when we look into some more detail, so if we look at the severe treatment emergent adverse effects, we actually see that those in the 400 milligram group experienced about 35.8% of those individuals experienced severe treatment emergent adverse effects compared to 32.1% in the 400 milligram, followed by a maintenance dose of 200. And all those were slightly less than those individuals in the Caspofungin group. In terms of serious adverse effects, again, the Caspofungin 400 and 200 maintenance dose, again, had the highest rate of serious adverse effects, 52.8 compared to 42.6 in the Caspofungin group. So a lot of the data that we're seeing so far seems to indicate that Rezafungin may be a little less safe in terms of the rates of adverse events, serious adverse events, in comparison to Caspofungin. Now, when we look at drug-related, specifically drug-related treatment emergent adverse effects, 8.6% in the 400 group, 11.6% in the Rezafungin group, and again, drug-related adverse events, the Caspofungin group had the highest in this case, so 13.2%. So that muddies up some of the safety data just a bit, but from the phase 3 trial, that if we think back to that study, we do see a little bit more in terms of side effects for this new agent. Most common adverse events were hypokalemia, diarrhea, and vomiting. Finally, we're going to look at Rezafungin versus fluconazole. So fluconazole is not a first-line agent for candidiasis or for our candidemia. So we're actually looking at vulvovaginal candidiasis. And now these products are not available. So I will review them very quickly, just to give you an oversight of these products and what they kind of looked at. So this is a phase 2 multi-center open label sponsored blinded controlled trial. There's few people in this. There's 99 patients. And they wanted to study an ointment and a gel formulation of Rezafungin in treatment of moderate to severe vulvovaginal candidiasis. And their goal was really to assess both safety and efficacy. So they used a 3% gel, and they had 40% recruited for that group. They used a 6% ointment, and they had 40 patients for that group. And they used our standard oral fluconazole, 150 milligrams, and had 19 patients in that group. Included patients that were 18 years of age or older. Those individuals with moderate to severe vulvovaginal candidiasis with a severity score of more than 7. And they excluded individuals who had a systemic antifungal therapy within the past 7 days, known or suspected infectious causes of vulvovaginitis other than candidiasis. And so when we look at some of the methods that they use, these individuals, again, were randomized 1:1:1 into these 3 treatment groups. 4 grams of Rezafungin vaginal gel were used in cohort 1. And this was done with a 3% concentration. In the second group, or in cohort 2, they used 4 grams of Rezafungin for a vaginal ointment. And this ointment was a bit higher concentration at 6%. And that final group is our oral fluconazole group, 500 milligrams in clinic on day 1. So those in cohorts 1 and 2 were allowed to use Rezafungin external gel with a concentration of 1% or Rezafungin external ointment with a concentration of 1%. For relief of symptoms as needed, and they could do this for up to 72 hours after their initial treatment. So after these folks were randomized, they were seen on day 7, 14, and 28, and they saw them and assessed the clinical cure and safety. Clinical cure was determined by the complete absence of all signs and symptoms indicated by a score of 0. Again, those individuals that were recruited had a score of 7. On the other hand, clinical failure, they define that as the presence of any of the 6 signs and symptoms of vulvovaginal candidiasis with a score greater than 1. Mycological eradication was confirmed by a negative vaginal culture for candidate species at the specified assessment time. So this took place over the course of a couple months from June 2016 to November 2016. They followed up at day 28. They were looking at clinical, mycological, and therapeutic cure by treatment date. The trend that you're going to see with the results here when we're looking at our endpoints. On day 7, 14, and 28, the results all appear to favor oral fluconazole 150 milligrams. So just specifically looking at clinical cure on day 7. Rezafungin gel, 37.5% of patients on Rezafungin gel experienced clinical cure at day 7, whereas slightly more on the 6% ointment, 40% experienced clinical cure, and with our standard of care oral fluconazole, 47.4% experienced clinical cure. So you can see like mycological endpoints for during day 7 that greatly favored oral fluconazole at 68% versus 40 and 55%. And then even at day 28, the Rezafungin groups never really caught up to clinical cure, mycological, and therapeutic cure. So as you might imagine, this product is not available at this time. Common adverse effects included infection in all treatment groups, bacterial vaginosis, nasopharyngitis. Nausea was also seen across the groups, as you might expect, although these were, for the most part, topical agents. Vaginal symptoms like pain, dyspareunia, edema, or burning sensations were most commonly seen in that higher concentration Rezafungin 6% ointment group as well. So having looked at those data, at the data that we have available, let's look at some of the conclusions that have been made about those studies. So in the RESTORE trial, that was our phase 3 randomized controlled trial using 400 milligram loading dose and our 200 milligram maintenance dose. And it looked solely at that versus caspofungin. 91% of patients in the Rezafungin group and 85% of those taking caspofungin had at least one treatment emergent adverse event. The most common treatment emergent adverse events occurred in at least 5% of patients were pyrexia, hypokalemia, pneumonia, septic shock, as well as anemia. 56% of patients in the Rezafungin group and 53 in the caspofungin group also had serious adverse effects. So while the outcome of the RESTORE study, the efficacy appeared to be similar to caspofungin, I think it brings up some cause for concern about not being quite as safe or well tolerated in those individuals. The STRIVE trial, this was our phase 2 study that looked at various doses of Rezafungin. It appeared to be safe and efficacious in the treatment group for candidemia. And I think it's also important to note that this study also highlighted the fact that, hey, safety in terms of serious side effects may favor caspofungin over Rezafungin. So again, just keep an eye out for that. And then finally, with our Rezafungin and fluconazole group, really not enough data to support that dosage form at this time. There really needs to be a lot more data to evaluate that. So let's critique some of the literature. RESTORE, our phase 3 study, we want to highlight the fact that this study excluded patients, especially pediatric patients, and those with certain forms of more difficult to treat candidiasis. And so that really overall limits the applicability. So even though the efficacy appeared to be similar to caspofungin, we weren't necessarily dealing with the most difficult treatment, difficult patients to treat. A lot of those were excluded. So we don't have a whole lot of data to really support it in a wide population. STRIVE 2, again, not powered to draw conclusions about statistical significance, even though it seemed like Rezafungin may be more superior to some degree in terms of its comparison to caspofungin. We don't really have data to support that from the STRIVE trial, and we don't have the data to support that with the RESTORE trial either. And then finally, with the Rezafungin and fluconazole group, very small study, really didn't have any results to favor Rezafungin whatsoever over fluconazole. In terms of thinking how we want to implement this in clinical practice, the major selling point really for Rezafungin is the once weekly administration. It's easier for patients to adhere to that, or at least for some patients, maybe more convenient for some and possibly less convenient for others. It has better solubility and stability characteristics compared to some of the first generation's antifungals as well. And that's one of the reasons why that allows it to have this once weekly dosing, as well as the half-life, which is extremely long. This is, again, a kind of candid medication. These are first-line therapy for candidemia and for other multiple conditions. And so falling into that class at least sets us up for certain types of individuals who as a potential first-line agent at some point to be chosen for individuals who might prefer this once-weekly dosing. So it's still important to consider the tolerability of the agent. In our phase 3, phase 2 studies do seem to indicate that it may not be as well tolerated as our other agents on the market right now. So it would be nice to get some more data on that. Let's do a brief review before we wrap things up. And if there are any questions, feel free to leave those in the chat. So what I'll have you do is I'll read the question and give you a moment. And then go ahead and type your answer into the chat box. And I'll give you a minute to find that. All right. So our first question is, what pharmacological class does Rezafungin belong to? Looks like I'm seeing some votes for C, the echinocandins. All right, so you guys are all correct. The answer is echinocandins. All right. So our next question is, what is the correct dose for Rezafungin? 400 once a day, then 200 weekly, 400 twice a week on week one, then 200 milligrams daily. 200 milligrams once on day one, then 400 milligrams weekly, or 200 milligrams twice on week one, then 400 milligrams once weekly. Like I'm seeing some votes for A. A, that's correct. That's the correct answer. I'll circle it here. Fantastic. All right. What is considered an advantage of using Rezafungin in clinical practice? Does it significantly improve 30-day mortality over Caspofungin? Is it longer acting? Does it provide much fewer toxicities when compared to other agents, or all of the above? So I changed this one up shortly before the presentation a little bit to be a little bit tricky. So in terms of 30-day mortality, not seeing actual benefit in terms of 30-day mortality or statistical benefit over Caspofungin. It does work longer. It does have a longer half-life. It's a once weekly dosing, so that is certainly a benefit. And in terms of toxicities, it doesn't have much less toxicities compared to other agents. In fact, it may have more. So the correct answer there is going to be B. It's longer acting. And you can give it over a week. So what was not considered an outcome when assessing the data associated with Rezafungin? Did we not look at clinical cure? Did we not look at 30-day mortality, mycological eradication, or 14-day mortality? This one gets into the some of the minutia of the studies. Hope I didn't bore anyone to death by the time we got to those studies. And some votes for D. And D is correct. D is indeed correct. So 14-day mortality, we didn't look at that. We looked at 30-day mortality. So again, just a little small detail there. And our last question. What formulation of Rezafungin was not studied in the data discussed? IV, gel, ointment, or oral? Yeah, well, that's right. So it's D. It's D. So we looked at IV, that's the FDA approved dosage form. Gel and ointment have not been approved. They looked at that compared to fluconazole. It did not appear to be as good as fluconazole for vulvovaginal candidiasis. And there's no oral formulation for this at this time. So that is all that I have.